So it's my pleasure now to invite Dr. Rajeev Tomar, a well-established consultant pediatrician and pediatric hepatologist at King's College Dubai. With more than 24 years of experience, he trained in the UK and India and in two elite centers within London, Great Ormond Street Hospital and King's College. So Dr. Rajeev Tomar will give us a talk today about approach to jaundiced child with a hepatologist request. Dr. Rajeev.
Thank you very much. Thank you so much. So thanks for your kind words. And first of all, a big thank you to Dr. Magdadi and the entire organization team for such a good conference and giving me an opportunity to talk about a very interesting but a challenging topic. Interesting because jaundice, child can have jaundice for multiple reasons. Challenging is to try to do justice for this topic in 20 minutes. So I have nothing to disclose. So I have taken the liberty to exclude certain causes in my presentation because I'm sure in the past couple of days, there have been excellent talks covering these topics. So I have excluded causes which involves onset in early infancy, typically like biliary atresia, bile acid synthesis disorders, defect syndromes, certain more endocrine causes like hypothyroidism, neutral hematomatosis. Not to forget conditions like PFIC, alpha-1 antitrypsin, your bile acid disorders, which do have onset in early infancy, can also present later in childhood. I'm also would be discussing about pure hematological causes, which are again easily diagnosed with good history taking, good clinical examination, baseline CBC with peripheral phlegm, like G6PD, your hereditary spherocytosis, and Gilbert syndrome is more like a clinical diagnosis. Surgical causes, again, good history taken with initial lab test and an ultrasonography will pick up majority of your surgical causes. So the way I plan to run this session is with the following objectives. It will be essentially case studies so that you can have a little bit of interaction and hopefully it can present in your daily practice and help you to make a diagnosis of these children. The case studies involves of my experience both in India, in the UK, and here also in UAE. So again, old teaching, a good clinical history and examination and lab studies will help you to arrive at diagnosis. We as hepatologists are blamed to request millions of tests, but believe me, if we have certain understanding of simple basic tests, you can narrow down your investigations to arrive to a diagnosis. So the way to approach jaundice child is whether you are dealing with an acute condition or whether this child had a chronic condition leading to jaundice, or is it something like acute on chronic? And let's figure out whether it's as easy as the way I've just mentioned. And these following case studies will tell you how to interpret these conditions. The multiple ways of approaching a jaundice child, classical has been pre-hepatic, hepatic, and post-hepatic. The way I try to practice mine is to look for an etiology if I can. Majority of the cases coming with acute hepatitis will be infective. Of course, not to forget autoimmune disorders, metabolic conditions, especially Wilson disease, where you'll get some cystic fibrosis and your alpha-1 antitrypsin storage disorders. And please not to forget to take a good medical history pertaining to a drug history, which is often ignored but can be a common cause in your clinical practice. So approaching a child with jaundice is no different from any other condition. You need a good history. For jaundice child, the key thing is the onset of jaundice. Were there any prodromal symptoms before the jaundice was seen in the child? Particular attention is for fever, because obviously fever in majority of the cases will indicate infective etiology. What happened to the fever once the child was seen to be jaundiced? Did it continued or did it stopped? Was there any bleeding? Was any rash? Was any itching? Bleeding can be part of parcel of acute infective etiologies. It can be also part of chronic liver disease. Rash, again, part of acute infective etiologies, can also be part of your chronic liver disease. Itching is very important. I think one message which I need to give you here is if you have a child with jaundice, the labs confirm it is cholestasis, and the child is not itching. I'm sure you've seen the board outside. Do your bile acids. If they are normal, think of bile acid synthetic disorders. So it's pretty straightforward. You should be able to diagnose this condition. If you miss that, these kids can end up into a chronic liver disease requiring liver transplant. Travel history is always important. If you practice in endemic areas, it's still important to remember. Drug history, I think I've emphasized enough. As regard to the examination, of course, you examine for chronic segment of liver disease. You look for encephalopathy. Again, it can be part and parcel of your liver failure, which is always a worry in a child with jaundice, or it can be part and parcel of your infective etiologies. Always examine the spleen and the liver. Try to see whether the child has predominantly hepatomegaly with no splenomegaly, or if the spleen is bigger than hepatomegaly. That can also help you to make a diagnosis. These are the common lab tests, which all of us will probably do. They're very commonly requested, but very commonly ignored. But mind you, these can give you a lot of information. Hemoglobin, again, is low for multiple causes. TLC, please make a note if there is any lymphopenia, there is pancytopenia. Platelets, again, they can be low and high. Low because of certain infective etiologies, low because of chronic liver disease, because they have splenomegaly, they consume. They can be high because of any autoimmune inflammatory process. Bilirubin total and direct will always help you to figure out if it is mainly unconjugated jaundice, then you think of hematological disorders, but majority of the liver causes in a pediatric age group will be you'll have a conjugated jaundice. AST/ALT, I'm sure Dr. Naresh will talk about these functions in the future, but remember, they have no prognostic values. We all know ALT is more specific to the liver, then we wonder why we do the AST in the first place. The reason we always involve AST along with ALT is that it has a shorter half-life. So if there is any inflammation within the hepatocyte, you expect the AST to rise earlier, and vice versa. If the child is recovering, we find the AST to improve further. Very common practice and very useful practice post-liver transplant to look for any liver ejections. Gamma GT and ALP, again, they are part and parcel of any cholangiocytes injury, or again, high is very common, but low is even more important. Both gamma GT and ALP, we'll discuss that with the case studies. Total protein and albumin. Albumin, again, is a mark of a chronic liver disease. It has a very high, longer life, half-life of 20 days. But more importantly is that if your lab is not giving you a total globulin, please do some mathematics. You subtract the albumin from the total protein, that gives you a globulin. And if that is high, that can be an indicator of your autoimmune hepatitis. So little small things can give you a lot of clues. INR is mandatory. It's a crime not to do an INR in a child who has jaundice. As Dr. Naresh has mentioned, it has depended upon factor 7, which has the shortest half-life, which will give you an indication of your failing liver. Kidney function test, and of course, we all do hepatitis screen, hepatitis A, B, C, E, EBV, CMV, and of course, in current scenario, you also include adenovirus nowadays. You always require ultrasound if it is predominantly conjugated jaundice to rule out any surgical cases to deal with, and also helps you to identify any signs of chronic liver disease. So let's start with case 1. Pretty straightforward, 8-year-old, fever for 8 days, fever stopped, jaundice appeared for 2 days, child is coming with no signs of any bleeding, rash, has a little of dark color urine. There was a travel history to India. Examination, essentially no chronic signs of liver disease. Examination, tender hepatomegaly. You do labs. You find, of course, normal CBC, very high AST/ALT. It means there is a rapid inflammation in the hepatocytes. And the albumin and INR is essentially normal, so essentially ruling out any chronic liver disease. You do hepatitis screen. Is positive for IgA. So this is pretty straightforward, and I wish pediatric hepatology could be as easy as this child. So what happens if When do you have to start broaden your thinking if the hepatitis A is not there and you're dealing with a child who has acute presentation? You've done your hepatitis screen, hepatitis A is negative, so you need to wonder, am I dealing with something else? And these are the clues which you'll get. If the fever is persisting after the onset of jaundice, then think of other etiologies, and we'll discuss that. Is there an encephalopathy with organomegaly? Remember, a jaundiced child who is encephalopathic, you always worried about acute liver failure. But there are other infective reasons where the child can present with early encephalopathy, which is not related to acute liver failure. Is there any associated renal failure? Again, I'm talking about acute presentations. Yes, you can get in leptospirosis and dengue if you practice in endemic areas. Biphasic illness is very important. Again, good clinical history will give the clue here. Seen typically in leptospirosis and dengue. If there is significant anemia, again, malaria, and thrombocytopenia, again, typically in dengue. So these are the common things to remember because they are easily treatable, a cause of child who looks very unwell with jaundice. So let's start with the second case. A 6-year-old fever for 10 days, persisting jaundice was seen 2 days ago. Again, traveled to India. On examination, he had pallor. He was looking at encephalopathy. And organomegaly was here, typically both hepatosplenomegaly. You do the CBC, there's mild anemia. Lymphopenia is typical here. Platelets were normal. Look at the AST, ALT, and gamma-gytin ALP. So mild transaminitis, the ALP is increased, and interestingly, the ALP is more than the ALT. Remember, ALT is within the hepatocytes. This is a disease which is involving as a more infiltrative process rather than more infective process in the hepatocytes. You look at the albumin, it's normal, so essentially going against chronic liver disease. Liver was slightly, INR was slightly abnormal, corrected with your IV vitamin K. Hepatitis screen was normal. Ultrasound showed hepatosplenomegaly and there was no ascites. Remember, ultrasound is not to look for how big your liver and spleen is, but to look for signs of chronic liver disease. If your liver has homogeneous appearance of ultrasound, it's probably an acute process. But if it is heterogeneous with splenomegaly, with ascites, it favors a diagnosis of chronic liver disease. Again, favors. So, of course, blood culture came with salmon typhi, and it was diagnosed with, with your typhoid. The reason for this child to have this jaundice. Again, I just mentioned mild jaundice, mild transaminase. ALP will be much higher than ALT. So this is easy. Next, case 3, a 9-year-old child with fever, lot of chills, very bad severe muscle ache for a few days. Interestingly, gets better, but then gets unwell, develop jaundice with reduced urine pouch. Again, typical biphasic history here. On examination, he looks quite deeply jaundiced, but there is no encephalopathy. Child has a big liver, typically will not have any spleen here. You do the CBC and the TLC, again, normal presentations in terms of CBC. Not surprisingly, the bilirubin is predominantly conjugated. The AST here is bigger than the ALT, it's higher than the AST. And probably this is because of the severe chilling and muscular activities the child was having. The gamma-gytin ALP is expectedly high because it's topical conjugated jaundice. Albumin is normal, iron is normal, again, going against your chronic liver disease. The kidney functions are abnormal. The CPK suspected was high because of this muscle involvement. Your hepatitis screen is negatively, when ultrasound is just shows hepatomegaly with no splenomegaly, with no ascites, again going against chronic liver disease. So this is actually a typical presentation of leptospirosis. Remember, in a nutshell, if you have any child with biphasic illness, with severe myalgia, a lot of chills, severe muscular pain, examination may also find some congenital, conjunctivitis confession. It's a typical hepatomegaly with no splenomegaly, no signs of chronic liver disease. Please think of leptospirosis. Case 4, 5-year-old girl coming with fever for 7 days, a lot of chills, jaundice for 2 days, has a reduced urine output, severely pale, also ecteric, is encephalopathic, and organomegaly showing mainly more of liver and also of spleen. Hemoglobin shows severe anemia. Bilirubin, typical, if you see 1.7 out of 14 is unconjugated jaundice, suggesting there is more of a hemolysis going on rather than the involvement of the liver. AST is quite high again because they have a lot of chills. INR is normal. Again, as Dr. Naresh mentioned, for synthetic function, you are doing your INRs, you're doing your albumin. But remember, if you have an Indian child who's jaundice, always do a blood sugar, try to do a gas, try to do ammonia. These are also your functional indicators of your liver disease. Straightforward, I'll quickly rush through. Malaria, you treat. This is again, typically anemia, hypoglycemia, acidosis. Now, this is interesting. So, this is a 4-year-old child with history of fever and had fever 10 days ago, was treated for, was treated and then referred to me because he was supposed to get his operation done for undescended testis. And initial workup showed he had abnormal liver function test. So if you see here that the counts are normal, the AST-ALT is high, but more interestingly, the gamma-GT-ALP is much, much higher. The albumin is normal, the INR is normal, again, going against any chronic liver disease. KFT was normal, hepatitis C was normal, ultrasound was also normal in this child. So did I miss here something? Yes, I did. So if you dig in more further, this child had a history of tonsillitis who was treated with Augmentin. And yes, I didn't mention about the differential. The importance of differential here is this child had eosinophilia. And then you could easily label this was Augmentin-induced cholestasis. A very common antibiotics done. The reason I pulled up this case is we often neglect a very detailed medical history pertaining to drug intake. Augmentin, I'm sure everybody uses it, but nobody thinks about cholestasis, jaundice because of Augmentin. Yes, it's not dose dependent. It is idiosyncratic reaction, but it can happen. The clue will come from eosinophilia. Again, a simple CBC differential count. But here, typically the ALP and gamma-GT are much, much higher. Another common scenario is when patients are referred to isolated gamma-GT rise, and just to take a detailed history and they're on some valproates, that can cause an isolated increase in gamma-GT. Briefly mentioned, it can be hepatocellular cholestatic jaundice and mixed. The list is huge, but I just pulled out the one which are more common in our practice. Amoxicillin, azithromycin. If you practice in endemic areas, your ATTs, your antitubercular medications, antiepileptics, I'm sure everybody deals with valproates and lamotrigine. ADHD is increasingly being, I'm not sure, diagnosed, overdiagnosed, the better learning, but they are all methylphenidate. They come to my clinic with this abnormal liver function test. Antidepressant, again, teenagers, they are on fluoxetine more often, and they can have this abnormal liver function test. Not to forget the big herbal group. Okay, so more practical approach. Or can you just go to next? Yes. More importantly is patient will ask you, doctor, do I need to stop this medication if you're blaming this medication? And the golden rule is, okay, fine. If your ALT, AST have gone above the 5 times the normal with no other symptoms, you need to stop. Or if you have some symptoms because, itching, jaundice is developing, and it's more than 3 times, you need to ask your treating physician to try to change to a different medications. Or if the bilirubin and ALP goes above 2 times the normal. So it's always a good practice if you're starting any medication which is known to be hepatotoxic to have some baseline liver function test done, and that helps you guide your therapies in case things go wrong. So next case, this is a child with a 4-year-old who had fever for 10 days, jaundice for 1 day, but looked very, very unwell. Had pallor, had general lymphadenopathy, organomegaly. Here, the spleen was big, massive splenomegaly compared to hepatomegaly. Counts, you can see, it's all pancytopenia, low hemoglobin, low counts, no platelets. Bilirubin is mildly increased, AST is borderline increased, INR is normal, and the hepatitis screen is negative. So I'm sure everybody will think about lymphoma, leukemia, and the key thing here is HLH. You order certain more tests. Typically, please order a fasting triglyceride, ferritin, and fibrinogenemia and a peripheral phlegm, and this can help you to make a diagnosis. Bone marrow, of course, clinch the diagnosis. The message here really from my side is, we all as a pediatrician are very well aware of any child who has fever beyond 5 days to think of Kawasaki disease. The message I want to share with you guys is, any child after 7 days who's looking of fever, who's looking unwell, please think of HLH. Please palpate their abdomen. If the spleen is big and you have pancytopenia, that's an urgent referral. Okay, next one. This is a child who is 4-year-old girl. Now this child had prodrome for 6 days. But this time, the jaundice started after prodrome, but lingered on for good 24 days. There is a history of abdominal distension, who was locally treated with some diuretics. And if you dig more, there was no significant past medical history. So this doesn't sound a very acute condition, but we will see, because there is a prodrome before the onset of jaundice, you think of some acute insult here. You examine the child has X-rays, there's no edema. The child looks stunted, she's small for her age. No encephalopathy, no organomegaly, no signs of chronic liver disease. We're not sure on examination, there was no ascites, but we're really not sure because the child was given diuretics before the child came to us. So are we dealing in this scenario a child who has acute presentation, or a child has an underlying chronic liver disease, or is it acute and chronic liver failure? It can be acute because, as I said, prodrome before the onset of jaundice. Again, this was in India, so you may have multiple viral infections in isolation or in combination. There was no drug history in this case. And for chronic liver disease, Wilson, autoimmune, and metabolic liver disease were considered. Just a message here. Any child who's above 2 years of age comes to you with liver disorders and you've ruled out infective etiologies, please always think of autoimmune hepatitis and Wilson disease. Their presentation can be quite variable. It can be an isolated finding on routine blood tests. They can present with very acute conditions, or they can present as acute and chronic disease. So the message here really is about think of autoimmune hepatitis and Wilson disease for any child who's coming with multiple different presentations. So where were we here till now? So there was a child who has a history of very short duration of jaundice, which was preceded by a prodrome, thinking whether it is an infective etiology, but it decompensated because there was an ascites which happened within 4 weeks. The child was stunted, so is this something which is going on chronically, but there was no stigmata of chronic liver disease on examination. There was no hepatosplenomegaly in this case. Typically, this child did not also have fever. So, sorry? Okay, I'll try to speed up. So is there everything which is acute? Yes, it can be possible because acute viral hepatitis can have an atypical course in 20% of cases. They can have prolonged cholestasis, ascites, and even relapsing hepatitis. Remember, hepatitis A generally does not have a relapsing course, but it can happen. Or is it an acute manifestation of chronic liver disease? She's a girl, they're more prone for autoimmune hepatitis, and 1/3 can present with acute hepatitis. So this is the investigations which we did. Again, just to highlight the importance of subtracting the albumin from total protein, you'll see the globulins are very high. The INR is 1.8. The albumin is low. These parameters are suggesting this might be something which is chronically which is going on. And ultrasound also confirmed she had a coarse ecotexture. There's something which is irritating the liver for a while. So what you do, you look for 2 things, autoimmune hepatitis and Wilson disease. Autoimmune hepatitis look for mainly total IgG, you look for antibodies, ANA, smooth muscle LPM, and for Wilson, you do your ceruloplasmin and for urine collection. If possible, get an ophthalmologist to look for KF rings. So in this scenario, of course, if you look at the markers, not all are very positive, so you have to go ahead and do a liver biopsy, liver biopsy was suggestive of autoimmune hepatitis. This is a scoring chart, very important. Autoantibodies, you score IgG, liver histology. Important thing to remember is liver histology can also be compatible or typical. Okay, you have to ensure there is no viral infection to move this. The score for this child was 8/8. We label it as autoimmune hepatitis type 1 because the SMA was positive here. So I'll just quickly skip because we're short of time, but these are the features to look for. But is finding an autoantibodies in a blood test confirms the diagnosis of autoimmune hepatitis? The answer is big no. Okay, you can have falsely positive autoimmune hepatitis in chronic disease which have a known etiology, which is not because of autoimmune hepatitis. So if from adult studies, it's pretty obvious. The more commonest cause of CLD is your hepatitis C, B, and alcohol. And there's almost 1/3 to 40% patient will have a positive antibodies. The cryptogenic is even higher. And remember, the IgG levels were either normal or high in all those cases. The message which I'm trying to tell you is, if you detect autoantibodies in CLD, do not assume it is a confirmation. You need a liver biopsy to confirm the diagnosis. Also, not to confuse you, even acute hepatitis can occasionally present with positive false antibodies. I'll just mention about the hepatitis E can have a very high percentage of ALA and SMA. And if you check these antibodies on follow-up, they can be positive for 12 months. Again, a good history of previous hepatitis E infection with low titers, maybe because of the previous acute hepatitis rather than autoimmune hepatitis. So this is, again, I'll quickly go through 7-year-old obese patient. Again, acute onset, had pallor, no encephalopathy or ganglion was there. And if you look at the parameters here, just focus on the AST, ALT, and gamma GB. ALT is relatively low compared to the fact that the patient has conjugated jaundice. Albumin was 3, INR was deranged, ultrasound was coarse, again suggesting probably this child had acute insult on a chronic liver disease patient. So again, we always screen for autoimmune hepatitis. Wilson disease, I've highlighted enough, not very typical. One of the antibodies is positive, N is negative, IgG is high, but LKM is negative. Wilson's, look for KF rings, cerebroplasm. Again, remember, cerebroplasm less than 40 is abnormal, less than 20 is quite significant. So this was a significant cerebroplasmin find, and of course, 24 unicopper was quite high. Normal above 40 is taken as positive. If you go by the same scoring for the autoimmune hepatitis, she was only scoring 5. So that's not confirmation for autoimmune hepatitis. So we got the things done. Cerebral, as I said, was low. KF ring was positive in this child. Urine copper was quite high. So according to ACLD, it's almost fitting the diagnosis of Wilson disease. If the child is not, if it's stable enough to do a liver biopsy, that's always recommended. But not all centers are doing a dry copper weight in the liver biopsies, but this should be good enough to think if all 3 are positive. If any of the 2 things are positive, then the patient would need liver biopsy. Okay, fine. Last case, I think it was interesting, but I'll quickly skip. 8-year-old child with jaundice, generalized abdominal distension. This child had a very dark Coca-Cola colored urine, which is indicator of IV hemolysis. But developed ascites, and he was a boy, so think of G6PD. Boss, can we just put, yeah. Let me just rush through this. But the liver examination was quite firm here, again favoring chronic liver disease. Yes, if you do the investigation, the hemoglobin is quite low, that again indicating IV hemolysis. The counts were high, the platelets was low, but look at the ALP here, it's quite low. In a child who's so sick, look at the ALT, AST, they are almost not very high, but the INR is 4.4. As mentioned earlier, if you have high INR with low AST, that means the liver is almost failing because there's not enough liver mass left to increase the AST and ALT. To make things worse, the IgM HAV came as positive. So it was again acute liver failure because of your hepatitis A, but there were parameters suggesting this child had underlying chronic liver disease. or could it be Wilson, could it be autoimmune hepatitis? But I'll just skip through that. Wilson, this child actually had normal cerebral. And just quick message about cerebral. I'll mention to you. So serum cerebellum is an inflammatory marker. It can be increased in an acute condition. Since it's synthesized in the liver, it can be low in any chronic liver disease patient. So one isolated cerebroplasm is not the way to diagnose Wilson disease. You need other parameters. And in this typical case, with an acute presentation, with very high INR, with very low alkaline phosphatase, think of fulminant Wilson disease, and this child needs to be referred to an early referral to a liver transplant center. And this child did actually well after this. So this is my conclusion slides. Acute hepatitis with persistent fever, consider other infective causes besides hepatitis A. Fever, jaundice, encephalopathy, yes, it's a sign of liver failure, but there are certain conditions like typhoid, dengue, and malaria which can cause this, and they are easily treatable. Acute hepatitis or LF with persistent fever, please remember HLH, especially if the fever has been more than 7 days. Acute hepatitis, never ever forget drug-induced liver injury. And remember, acute hepatitis can be a presentation of autoimmune hepatitis, but depending solely on a positive antibody is not the right thing. Keep mind about the false positivity. Liver biopsy has to be started before you give steroids in autoimmune hepatitis. And Wilson disease can present as fulminant liver failure. And not to forget to include investigation for adenovirus because of the current scenario. Sorry to rush the last case. Thank you very much. I'm open for question.